Can you hear us, Dr. Nordbeck?
Yes, I can hear you very well. Thank you for the kind introduction. And it's my great pleasure to discuss with you the Carillon device. I hope you can see my slides nicely now. So the question is why Carillon should be in your toolbox. So first of all, secondary mitral regurgitation, of course, is a highly prevalent disease. We have really a huge portion of our patients who are at least at high risk or even actually affected. Basically, every patient with heart failure, but also coronary artery disease, AFib, these are all at high risk or even. And if we think about heart failure and mitral regurgitation, then we know that timing is really key in managing these patients. We've seen this sketch or similar ones many times, and we all know that the patients with heart failure, they deteriorate. They often, when they are deteriorating, have an increase in their mitral regurgitation, and after their decompensation phases, it's often tough to get them back to state before. So what we're really aiming at is early intervention. Of course, early therapy with medication, if that is possible, but that's only the basis, and we often need interventions. And I think the 2025 ESC guidelines have appreciated the fact that we have already good data that early interventions there or can be amended by the guideline. Directed therapy can be amended by catheter-based interventions, with the tier now having a 1A indication, however, only for patients with symptomatic patients with impaired LVF, and also fulfilling the specific clinical and echocardiographically criteria, which has been proven that there is a positive effect. And a large proportion of our patients is still in these other categories to be usually, but the same is also true for surgery, obviously. So we lack actually currently good tools we are frequently using in the patients, and therefore the question is the Carillon the better alternative in this large number of patients? And if you've seen a case before, recently, I don't want to have too much overlap or repetition here, but just the sketch on the right showing how the device is working actually. So cinching really the annulus through the coronary sinus. And here below in the visible heart model, you can see how that translates to the valves. And this is one of my cases, which I've done. You can see on the left-hand side, the baseline, middle is directly post-implant, where you can appreciate here, shortly above the valves, the device actually in the echo. And at 3 months already, you can see that not only the mitral regurgitation has improved, but also the morphology and functioning of the heart muscle, both the atrium and the left ventricle, has greatly improved. So the device is not new. We've seen a couple of trials in the past focusing on the device and its effects. So efficacy on reduction of MR has been nicely proven in the short run, but also for 5 years already, showing that it is feasible to improve functional regurgitation in the majority of patients. We also have pretty good data showing that the left ventricle and also the left atrium usually improve with the device, not only the annulus. And I think what is especially important for the patient is that the quality of life greatly improves with the different measures we can use, New York Heart Association class, 6 minutes walk test, and walking test, and also KCCQ scores. And this is something which I also really frequently see in my clinical practice, that patients really benefit with their quality of life from this procedure. Last but not least, I think it's important, of course, to talk about safety, especially when we think about early intervention. So in the beginning, I was saying that the time span we see for intervention. So at the moment, mostly targeting those late stage heart failure patients is, of course, at least in part, caused by the knowing that we want to be a low risk with our patients. And we've seen in a couple of research work over the last years that with the Carillon, really severe complications are really very low. One of the major issues we've been discussing in the past a lot is CRT, because the candidates with left ventricular dysfunction, they are often good candidates for CRT, of course, and there is a big hesitation whether this might cause trouble. And so from my personal experience, I just on this slide I brought a case with the Carillon inside before. This is a patient who already had a single chamber ICD before, and on the right-hand side top you can see the Carillon inside with a balloon inserted, showing the coronary sinus and the branches, the venous branches, and afterward below how the left ventricular lead in this side, in this case, was inserted into a lateral branch. This is really usually doable very easily without any problems. The other round, it's obviously maybe a bit more complicated. So if you have a patient where there is already a CRT lead in place, this might cause, of course, a bit more hesitation to consider the Carillon in these cases as well. We did a dual center study now because we and others did individual patients with the Carillon device who already had a CRT before. 21 patients were treated this way. You see below the CRT already in place, the coronary angiogram, and how the device is then implanted over the left ventricular lead, and the result in the echo on top. This is our findings in 21 patients now. We had one patient where it was not possible to implant the Carillon device afterwards due to anatomical reasons. In all the other cases, it was possible to implant the device, and so far we had no problems with the CRT device caused by the Carillon implanted after, and also a very good functional result, making this also for these patients, I think, a very good treatment alternative. I would like to sum up. So the Carillon is a minimally invasive, usually very quick procedure. It has many strengths, among them that no TEE or deep sedation is needed. The device is fully recapturable till it's finally deployed. The valve leaflets are not touched, which is, I think, really a big pro. And as I've shown you, this also means that usually all future treatment options are preserved. And this makes the device, in my view, really the ideal treatment for secondary mitral regurgitation, especially at an early state, regardless of the underlying disease. Thank you very much, and I'm happy to take any questions.
Thank you, Dr. Nordbeck, for this presentation, this introduction to the system and the effect it has on MR reduction and LV remodeling. I'm sure there are many questions here from the audience, but I'd like to start by saying, do you think this is an MR reduction device or LV remodeling device or both? And if it's both, which one is the predominant one?
I think that's an excellent question. This really focuses on what we are still working at. So I think it's a bit of both. So you often see a direct effect, but not in all cases. And in a high number of the cases where you really see only pretty slight improvement in directly after implantation, the patients still improve greatly in the long run. So I think larger of the effects we're seeing is really stabilization and remodeling, reverse remodeling of the annulus and the myocardium.
In the past, we had concern about the left circumflex. How many patients would you, from out of 100 that are screened, how many would you rule out for Carillon device because of that concern?
Yeah, that's also an excellent question. I mean, to be honest, this is also something which is a bit work in progress because, in my view, the only cases where I would be really hesitant about considering the device are those which are really dependent on the circumflex as the last remaining vessel, where actually we had cases, and I've already also treated one case where both the LID and the right were closed. But still, I think the circumflex is something which can cause problems if it's especially if it's a dominant branch. I mean, there's different approaches to tackle the problems you might encounter, and from my experience, it's a bit comparable to the Carillon, which maybe some have experienced. So I've been using the Carillon a lot for tricuspid regurgitation, and there you can see that when you have a certain amount of compression in the direct result, maybe just directly or 5 minutes after, that when you look the next day after, the majority of the problems you're seeing have resolved. And if you're still in doubt, then of course you're always open for stenting. And there are some centers who do that pretty liberally. They say, okay, if they are in doubt, then they put a stent after. And I've done that also in certain cases, and it is easily doable. So it is still a good option for those patients.
I think what is really awesome with this device is that you can adjust the sensing that you're going to apply. And I guess there is a range of how much sensing you will give as a final in this system. So how do you decide what is the range, first of all, of the sensing? I mean, is it 20%, 30% of the length? And how do you decide how much of this sensing you're going to apply?
Yeah, that's another excellent question. I mean, that's also very true. So it's when you apply the device, there is some kind of like a learning curve, and also probably some operator preference, how to deploy that, which anchor size to use. So there is a high number of different devices which you can apply. Also, where to deploy the distal and the proximal anchor, and choosing the length. So the way I try to do it is really using the long devices, so covering the majority or the biggest part of the coronary sinus I possibly can. So going very distal, and then I would rather not pull to the maximum, having maybe problems with the circumflex. but rather to leave a moderate tension there, because lots of the effects we discussed before, they are about preventing the ventricle from decompensating. So it's not so much the maximum direct compression we need to put on the annulus. It's more preventing from worsening, and therefore I try to cover the largest part I can. And if I see that there is trouble, for example, with the circumflex, but it's also about tension. If you deploy too much tension, then usually the device might slip, and that might cause problems, obviously. So therefore, I don't think in the majority of cases, I use moderate tension and see very good results with that.
So do you check with a coronary injection just before releasing the device that the circumflex or the diagonals are not pushed by the device? Do you do that?
Yeah, I mean, if you deploy the distal anchor and then you see that after I've deployed the distal anchor, I already do the first injection of the coronaries, and if the circumflex is like to a large degree affected, and it's just the device is on the edge of being pulled away, then usually you can fix that by pulling away from the coronaries, and you will still have a good result. If you're distal and you have deployed the device and there is like some compression, then and you are not able to pull the distal anchor away by pulling from the circumflex, then you can of course consider stenting rather than not treating or whatever. So I think stenting is of course always a choice you can consider. But if you do like the stepwise approach, showing the coronaries and the device before deployment of the distal anchor, then again after deploying the distal anchor, and then when applying force, you have good options to adjust. So far, actually, in my practice, we hadn't any case we didn't treat just due to the coronaries.
Thank you very much for being with us and all the insights. We bombarded you with technical questions. And let's go to the next presentation by Dr. Priebe-Brämer, the real-world experience with the Carillon device, our 200+ Carillon